Thank you very much, Jose and Eberhard. And again, it's uncommon for two surgeons to speak in a transcatheter meeting. So these are my disclosures. Uh, we know that TAVR since 2019 in this country for sure has been approved across all the risk profiles. And the writing was always on the wall that TAVR is going to be, surpass surgical valves. It's less invasive. Patients recover faster. But while all that's going on, we forgot the biggest thing and the biggest question in the room, and that all bioprosthetic valves degenerate. And this is a quote from Dr. Ionescu, who unfortunately passed away this just last month, is, if we put biological valves, they're going to fail. And we really forgot, with all this enthusiasm for 2 decades, what do we do after that? So if we think about this at present, and we assume that things are going to last for 10 years, if we implant this in patients who are 65, and in Asia, such as in Japan and Korea, at 75, patients are going to need second interventions. So the basic expectation, as always, is for our patients, is it has to be low risk, it has to have good hemodynamic results, because if we don't, then patients are going to come back sooner and older. That's really important. If I do a second intervention at age of 80, thinking this is good, but at 82, if that patient returns, the patient's actually it's older, more comorbidities, and surgical risk is going to be much higher. We have to maintain coronary access, or at least the flow. And preferably, I think all of us always forget, patients want biological valves because they don't want anticoagulation. So if I'm going to give anticoagulation, might as well put a mechanical valve and get done with. So we had excellent effort from Yuri Landis, Redo-TAVR registry. I'm not going to go into the details, but the important points. He classified, we are going to focus on the THV failures, which are more than 1 year after index failure, equal kind of balloon expandable, self-expandable valves. Of course, these are selected patients who are not suitable even for surgery probably, but suitable anatomically for Redo-TAVR. I think it's very important. When slides are shown to you, Redo-TAVR versus explant is bad or this one is bad, these are very selected patients. So these are not even apples to oranges. These are probably trees to animals. So I think we need to understand that these two groups are not same. So outcomes were encouraging in select group of patients, and at that time, the valve performance adequate, etc. So the conclusion, in general, you will hear from everyone, including me probably, saying, it is safe, let's just do it. And we just heard that from Dr. Sharma and Dr. Grube, that TAV in TAV is going to be the procedure of choice. But sure, what are the challenges? I think this is not the full story. So we are understanding a lot. We cannot extrapolate what we have learned in valve. Surgical valves are all same profile, similar design. TAVR valves are going to be very different. And Kendra showed a really nice case. It's a 29 valve, but had to be dilated again with a 23 balloon. So the inner dimension of the stent frame there is probably 23 dimension now. So it's not 29 number we should be latched on to. So what are the challenges? And this is a slide from one of my fellows 2 years ago, and he said it's going to be an art, and we are slowly, unraveling all this to make it into a logic. So let's have some important considerations in baggage. I think these are our asks as physicians, as heart team, that we want to have all these things when we do this procedure. And we need to now learn some new terminology. And you're going to hear about this in next 5 years a lot. It's not that complicated. But essentially, if we split all this, we will slowly become wiser in selecting, the appropriate patient, and then do the second TAV procedure with really good results. So there are terminologies such as risk planes, including neoskirt plane, coronary risk prediction, and leaflet overhang. Very important 4 key points. What is the compatibility? As you see here, unlike the surgical valves, which are all short profile, and the only thing changes in surgical valve is leaflets are inside or outside, TAVR valves are all different designs in terms of stent frame height, leaflet heights, etc. So this is first thing we need to understand. So usually speaking, most valves can be used if your first valve is a short valve, but only few valves can be used if your first valve is a tall valve. That's like a slightly, easier understanding in these terms. I split them into four: short, tall, and you can see that there are essentially four combinations: short in short, tall in tall, short in tall, and tall in short. It's very easy to remember. The most complicated complication in terms of understanding, not in terms of performance, is the last one, which is short in tall. I think it's very important to understand some fine nuances. The first nuance is, of course, when you implant a valve, the leaflets are going to get pinned out, and it forms what is known as a skirt or a tube graft. So we need to understand how it changes. And here, I can lower the height, and I can lower the neoskirt plane by implanting it slightly lower. Now, I don't want to implant it too low that I don't treat the valve, which is already abnormal. So there is a zone, as you can see, between the three lines. That's where I want to implant. So let's look at a couple of things, because we did mistakes initially. We said leaflet overhang is bad, so any leaflet which overhangs on the top is going to give a lot of problems. So let's implant it as high as possible in every valve, and which, if I do it this way, I get leaflet overhang in the valves on the right side of the screen. But of course, there is no coronary risk or lower coronary risk. So let's implant it high, but by doing that, as you see, we may actually obstruct the flow in the coronary. So we learned a lot that this is important. And the way we think about it is not very simple. These valves are not on the bench. Remember, these are in the patient. So the depth of the valve also can guide you into what level you want to implant. So for example, a very nicely deployed 3 millimeter valve, as Kendra showed, probably in this situation, if I implant very high, there's a chance that there will be a coronary risk. While if the valve was deeper from starting with, I can implant it the same height with no coronary risk. So I think we need to understand a lot, and Kendra has done immense amount of work in this. This is the first publication about coronary risk, and recently Stephanie Sellers presented this concept of leaflet overhang and impact on hemodynamics. So in general, you want to implant high only if there's no coronary risk. Otherwise, you can implant it slightly lower and accept better coronary flow, because honestly, coronary obstruction kills the patient on table. So we really don't want that. So we have a lot of these new concepts in CT analysis called coronary risk plane and neoskirt plane. Essentially, if your neoskirt plane is going to be higher than the expected coronary risk plane, you need to do CT analysis in detail to understand what are these distances. And currently, we recommend anything between 2 to 4 millimeter as a yellow zone, less than 2 is red, and more than 4 is, of course, a green zone. So this is currently what we follow, which is safe. You can do patients who are in the yellow zone, but with coronary protection. Second, TAVR sizing. This is an example of a Evolut R26 with a Sapien 23, which is the in vitro sizing. And you can see already that the valve not expanded fully, and there was risk of halt because of uneven and under expansion. So what we have slowly moved on is actually in vivo sizing, which makes sense to me. So in vivo sizing, this is another case, which is a 29 Evolut, but we're actually using a 23S3 here. The reasoning is we measure it at certain nodes which are specific to each valve, and then we use what is in vivo sizing. And in fact, in this patient, we have a more circular, fully expanded 23 with less risk of halt after 3 years. So I think this is going to be really important. We always recommend people that decide your position and then do the sizing. The reasoning is, if you see the valve on the right side, which is Evolut R34, it has a shape like this. So if you implant lower, generally your size may change. In 30% of patients, one size bigger sapien. So very important again, you want to choose your position of implant, then check the sizing, and err on the larger side than the lower. So we want this to be logical. We don't want this to be an art. At least every one of us can't be Leonardo da Vinci. So might as well be a really good physician and try and analyze. So what we're doing is, this app will be released in January. This is a Redo-TAVR app. Currently, we are doing the beta testing. We're going to give all of you a very nice step-by-step CT analysis first, And this CT analysis is going to guide you into what decisions to make. We are not going to tell people what decisions to make like valve in valve, where we tell you the size. We are going to actually guide you, give all the information to you so you can plan the case properly. And these are the steps in which this is going to guide you. It's going to also create a very nice visual summary. This is really important. Like very few centers, the operators analyze their own CTs. So if you are analyzing the CT 3 weeks before the case, how do you take that knowledge into the cath lab? So this is going to allow you to do that. This is going to give the operators the tool to interpret and to read your mind when you do the CT and then analyze it. And this app will be, I think, very useful. We are also going to collect a lot of data based on this systematic analysis and see how we do. So I'm going to stop at this, but I must say that Redo-TAVR we need to do more carefully. Thank you.
Thank you, Vinny. I think I can speak for every TAVR operator in the room that we can't wait for your app and hope that it will help us all treat our patients better. Last talk in the session is from Dr. Samir Kapadia, who has just arrived off the plane. Everybody knows Samir as a longtime director of the cath lab at the Cleveland Clinic and recently promoted to chairman of cardiovascular medicine at the Cleveland Clinic. And he's going to speak to us about minimalistic and ambulatory TAVR programs.